Welcome, everyone. I'm very excited to be here today. We have a very full and a very exciting day. Two main events. These are actually the first events of what is the 50th anniversary of our Health Services Research Center, today known as the Center for Health Services and Outcomes Research, and all of its companion centers. And our first event is something which I think is extremely timely, a panel on the future of health services research. We are very lucky that our own Danielle Whicher, who got her PhD with us about 5 or 6 years ago, was someone who helped really write the National Academy of Medicine's report on the future of health services research. I remember Danielle was the kind of person who, when she was a first-year doctoral student, Jody Siegel and I had started a new course on health, on comparative effectiveness research, and we asked Danielle, as a first-year doctoral student, to lecture in our course because she already had done so much work on the topic with Sean Tunis and others. And things have only been straight up from there. I got to spend some time with her boss this last weekend, Victor Zhao, and even he knew who she was. She's going to be giving us a review of the report, and then I'll actually introduce our distinguished panel, and who will help precipitate what I hope is really a good discussion about where health services research should be going. So, Danielle.
So, it's always a good thing when your boss knows who you are. So I'm really excited to be here today and talk to all of you about the future of health services research and hear your opinions on where the field should go next. I'm also really excited to see Samir Siddiqui in the audience, who just defended his PhD, but also played a really major role in helping me develop this publication. So what I'm going to talk to you about today is the future of health services research, and really focusing on a meeting and a publication that the National Academy of Medicine put out in November of last year. So what I plan to cover is why the National Academy of Medicine decided to cover this topic at this time, what we did in terms of how the meeting was structured, who was there. I'll talk about some of the main themes from the publication that I've brought with me. I have a few copies, probably not enough for everyone, but if you're interested in a hard copy, please let me know. And then I'll talk about some potential next steps from the field. Over the course of the presentation, I'll also raise a number of discussion questions that I've shared with the panelists, and I'm hoping we can talk about more during the remainder of the session. I'm starting off with the definition of health services research, just to make sure we're all on the same page in terms of what we're talking about. Health services research has been defined as a multidisciplinary field of scientific investigation that studies how social factors, financing systems, organizational structures and processes, health technologies, and personal health behaviors affect access to healthcare, the quality and cost of healthcare, and ultimately our health and well-being. Again, now I'll talk a little bit about why it is that the National Academy of Medicine decided to take on this topic at this time, or really in 2018. What we continue to hear from field leaders is that, ironically, at a time in which the appreciation has never been higher for both the need and potential for health services research, the political and financial support for sustenance and growth of the field appear to be weakening. So what you see on the left-hand side at the bottom of the screen is that health services is a relatively small portion of the overall funding for research and development in the United States. On the right-hand side, what you see is that while overall there has been a slight increase in the amount of available funds for health services research in recent years, the overall number of projects that have been funded in the field continues to decrease. In addition to that, both the 2018 and 2019 presidential budgets proposed folding the Agency for Healthcare Research and Quality into the National Institutes for Health. While that didn't happen, and while we have seen small increases in the available funding for ARC in recent years, overall the available funding for ARC is still lower now than it was in 2014. So this led a variety of individuals to tell us that health services research is at an inflection point, with questions being raised about the scope, scale, structure, and function of government support for the field. And so now is an important time for the field to re-examine its structure, function, and future priorities. Now I'll give a bit of background on what it is that we did to start to understand the future directions for the field. The first thing we did was put together a planning committee of field experts representing a variety of different stakeholder constituencies to help us think through how to structure a multi-day meeting to understand some priorities and future directions for the field of health services research. We also raised funds, and so I just want to make sure I thank our supporters, which include Academy Health, the American Association of Colleges of Nursing, the American Board of Family Medicine, the American Society of Anesthesiologists, the Association of American Medical Colleges, the Federation of American Hospitals, and the Robert Wood Johnson Foundation. So working over a period of 6 months, with the steering committee, we developed an agenda that would allow us to look at past accomplishments of the field of health services research, challenges and future priorities for the field, and then to think through how the field could organize itself and improve coordination among the various key players so that it was able to accomplish those priorities. The meeting was held on February 26th and 27th of 2018. In terms of participants, we had about 75 people representing researchers, both academic and non-academic researchers, federal and non-federal funders of health services research, and then evidence users, including payers, health systems representatives, patient advocates, professional societies, and standard-setting organizations. The meeting was held at the National Academy of Sciences building, which is what you see on the right. What we tried to do is really make sure we had a good, all the geographic regions of the United States represented in the room, and we also wanted to have an even balance between evidence producers or researchers and end users. So now I'll walk through some of the key themes of the publication. The publication is available for free at nam.edu/HSR. And again, I have a few copies if you'd like one. One of the sessions at the meeting covered the health services research funding ecosystem. So we had representatives from the major federal organizations, including the Agency for Healthcare Research and Quality, the National Institutes of Health, the VA, and the Centers for Medicare and Medicaid Services. We also had leadership from PCORI there. I put it kind of in the middle between federal organizations and foundations because it's not technically a federal organization, but it does get all of its money through the federal government. We heard from these organizations about their priorities and about some of the work they've done to coordinate with other major government agencies. At the bottom of the screen, I also included the Department of Housing and Urban Development, as well as the Department of Transportation and the Department of Labor, because one of the key themes that came up during the discussion is that These organizations should be doing more to engage with major funders of health services research because of the important role that social determinants of health play in health outcomes in the United States. So I just wanted to make that point here, and we'll return to this topic of social determinants of health throughout the presentation. It's mentioned numerous times throughout the publication as well. We also discussed the important role that private foundations play in supporting health services research. So I've listed some here, and we had representatives from some of these organizations at the meeting as well. But I do want to make the point that there are, of course, many more. What I have on the slide is the Robert Wood Johnson Foundation, the Commonwealth Fund, the California Healthcare Foundation, Blue Shield of California Foundation, the Peterson Center on Healthcare, the Gordon and Betty Moore Foundation, and the Bill and Melinda Gates Foundation. A couple of key questions were raised during this session, and I think it would be great to get into a conversation about these topics. The first is, how can funders do a better job coordinating funding efforts and engaging non-traditional federal and non-federal organizations in supporting health services research? And how can these organizations develop novel funding streams designed to support rapid turnaround in pilot projects aimed at informing healthcare delivery? A second panel at the meeting talked about the impact that health services research has had to date. And what we heard from one of the panelists is a summary of some of the top health services research projects that have gone on to inform major policy decisions in the United States. So the publication talks about 10 of these. There's, of course, many more, and I'm just highlighting 3 on this slide. The first one, of course, includes one of our panelists and talks about ambulatory care groups, a categorization of diagnoses for research and management. This research informed the development of adjusted clinical groups, or ACGs, which are, of course, widely used throughout the world. The Campbell article from 2007 talks about institutional academic industry relationships. And it informed discussions around the Sunshine Act, which makes it possible to tell if physicians are receiving any sort of gifts or donations from industry. And then the third article I'll talk about is Sommers from 2017, 3-year impacts of the Affordable Care Act, improved medical care and health among low-income adults. This showed that Medicaid expansion does, in fact, lead to improved health outcomes and informed discussions about Medicaid block granting programs. Health services research has also had a variety of other impacts on the healthcare system. I've just listed a few here that were mentioned, and they include quality improvement and quality metrics, risk adjustment, improving the experience of care, informing payment models, and improving patient safety. But what we also heard during the meeting, and this was a theme that we heard kind of over and over again, is that health services research has been less influential in informing more nuanced management and implementation decisions that health systems face, because these types of decisions aren't necessarily well matched to traditional academic systems of supporting and doing research. So again, this leads to a couple of key questions. How can schools of public health provide researchers with the skills they need to translate findings and implement them in practice? And how can researchers be incentivized and encouraged to work in settings outside of academia to develop skills in implementation science? A couple of other panels during the meeting focused on the current areas of focus for health services research, including types of issues that are being investigated and approaches that are being developed. So we heard about advancements in predictive analytics and the use of artificial intelligence to help tailor care to different patient populations, And we also heard about some challenges with integrating artificial intelligence into health systems and at the point of care. We also heard about some developments in paying for population health and transforming our current fee-for-service payment system. And we heard about some success stories with health systems engineering to improve care quality and safety, specifically during the meeting using the Toyota production system to improve healthcare. We also heard about some issues and approaches related to care access. The first being social determinants of health. We heard about the continued importance of social determinants and some challenges to integrating social determinants of health into health services research. We also heard about and had a discussion about the importance of protective community factors in terms of keeping people out of the healthcare system. Another topic of conversation was engaging communities and translating findings. Again, this relates to the earlier point I raised about the significance of implementation science. We heard about some new insurance benefit design issues, and really the focus of that conversation was how nuanced should we be when designing insurance benefits programs so that we make sure that we are lowering costs, but that we're not at the same time harming individuals. And finally, we heard about the importance of care coordination for patients with complex needs. We heard about some novel models in this area, but we also heard about the need for continued research in this area. The conversation then turned to the data infrastructure that's available to support health services research. There was a recognition among people in the room that there is a greater amount of electronic health data available now than ever before, and more data is currently being made available to researchers, but there's a significant number of challenges to actually using this data to do health services research. And those include the growth of proprietary data, the lack of follow-through on commitments to release data, legal challenges, poor data quality, the high cost of purchasing data, difficulties collecting and integrating patient-reported outcomes, limited data from community and primary care settings, and budget cuts to nationally representative surveys. So this led to a question that we discussed a bit at the meeting, but I would love to hear more about the panel's thoughts on this, and that is what are the key policy and cultural levers for improving data access and quality? Some that we heard about during the meeting are financing and providing additional funding for making data available, stronger information blocking policies, and we've recently seen both the Office of the National Coordinator for Health IT and the Center for Medicare and Medicaid Services release proposed rules to prevent information blocking, so we could see some movement there. Addressing privacy concerns and questions about the Health Insurance Portability and Accountability Act, and demonstrating value to end users. And this notion of the importance of continuing to demonstrate value is another key theme we continue to hear about over the course of the 2 days. So now I'll talk a little bit about the next steps. The second day of the meeting was really focused on, given everything we heard, what are the priorities for the field and how can the field coordinate better to allow it to address those priorities. From a multi-stakeholder panel, we heard about a variety of different topics, both priorities related to what research should be done and priorities surrounding how to improve the infrastructure to support health services research in the United States. On the research side, we heard about the importance of continuing to investigate alternative payment models, to look at the impact of quality measures on health and healthcare outcomes, to investigate how to appropriately implement artificial intelligence models in healthcare settings and in health systems. We also heard about the importance of investigating levers for behavior change for complex conditions, and about continuing to look for new models of care that can help prevent clinician burnout and that can help improve care for high-need patients. And then we heard about the importance of conducting research to understand and mitigate the risks of the changing financial burden of care. With regard to infrastructure, we heard about the need to capture and integrate data on social determinants of health. I've touched on that a few times during the course of this presentation. On the importance of sharing and using reliable electronic health data, on the importance of addressing the misalignment of incentives in academia and related incentivizing implementation science. We also returned to a discussion of funding models and methods for doing rapid cycle research that can support policy and health systems level decision making. And about the importance of embedding health services research skills and tools in care delivery. And the final thing we talked about is the importance of engaging consumers and making sure that we are both addressing priorities that are important to the consumer and then communicating with consumers about the results of those studies. So in order to address the wide-ranging priorities that were discussed, the final part of the day focused on the way that the field should be organized and how to coordinate in order to address those priorities. The first thing we discussed was the need to establish a clear vision and goals for the field that are agreed upon by the variety of stakeholders who both generate health services research and then are supposed to be using that evidence to improve care. We also discussed the need to identify a set of metrics to measure progress, so that gets to the fifth bullet point about demonstrating value. We also heard about the need to establish collaborative governance and coordination structures for federal and non-federal funders. There's a recognition that there was some effort to coordinate among the federal funders, but that there really needs to be a lot more and that there should be engagement of other types of federal organizations as well. We talked about the need to foster the development of the data infrastructure and research teams required for real-time insights. And then we spent a good amount of time talking about the need for the field to demonstrate value in improving healthcare and health policy, and really focusing on developing a communication strategy to allow the field to talk to consumers and policymakers about the impact that it has. There was a feeling that really one of the big problems and one of the reasons that we continue to see these calls for ARC to be rolled into the NIH is because the field isn't doing a good job communicating its value. The kind of overriding theme at the end of the meeting was that the pace of change in health and healthcare is so rapid and the cost so substantial that a strong agenda and investment in health services research is essential to ensure the capture of emerging opportunities in a health system that yields better outcomes at a lower cost. And before I end, I do want to just raise the point that there has been some follow-up work after this meeting. RAND is currently conducting an ARC-funded, congressionally mandated study on health services in primary care research. The objectives of that study are to assess the current state of federally funded health services in primary care research and to identify gaps, areas of overlap, and strategies to improve coordination. And their deliverable is a strategic framework for future federal investments. And with that, I think we'll turn to the reactor panel, and I just want to leave up the key questions that I touched on over the course of this presentation. You want to see it here?
So thanks very much. That was both succinct and directed us to some key questions. I'm looking at our illustrious panel, and I know that their comments will be important, and perhaps some of them will be succinct too. So we have here to give us their thoughts and to perhaps help answer some of these questions. I hope people in the audience will also participate in at least proposing answers to these questions. First of all, we have Darrell Gaskin, who's a professor in health policy and management. He's actually the William C. and Nancy Richardson Professor, and is both a health services researcher and health economist, and has done outstanding work in classic health services research and also in health disparities. We have a relatively recent grad, Claudia Salzberg, who nonetheless has advanced rapidly, and after a little time at Penn, is now vice president for quality at the Federation of American Hospitals, which is a group of, is that correct? Is it for-profit?
Investor-owned hospitals.
Investor-owned hospitals, that's what I meant. So a group that's very interested in value. And I think that she can really give us a slightly different perspective, not necessarily where her heart lives, but where she sits. We have our own Jonathan Weiner, who's professor of health policy and management and runs our Center for Population Health IT, and is one of the parents of the ACG system that you've heard mentioned from the podium, and has also taught some of our core HSR courses for I would say years, but I mean to say decades. And then finally, of course, we have Steve Shortell, who I won't introduce at great length, but Steve is our visiting professor for the day, and he is the Blue Cross of California Distinguished Professor of Health Policy and Management at Berkeley, and also a former dean at Berkeley, and has been doing health services research more or less since it was invented. So, great group. I will call. Do any of you have any initial thoughts on these questions, or just the topic in general? Whoever hits the buzzer first may speak.
Would you go first, or would you like to go? Well, first of all, I'd like to thank Danielle for a great presentation and a great report. It does us proud. She was, a trained health services researcher here, and it's also extremely fitting as part of the Sam Shapiro Day and the 50th anniversary of Cheshire, because there's always been a confluence between Institute of Medicine, now National Academy of Medicine, and Academy of Health, previously Association for Health Services Research, and Johns Hopkins. And so it's fitting that this program here was either the first or the second to train health services researchers. And among those that trained, the very first thing that they did was form Academy Health, or they were key, 2 or 3 of the people were key. And as soon as it was then called Association for Health Services Research, and then obviously figuring out where the field should head, the Institute of Medicine has always been involved. So your report, which is future oriented, is really, if you pull together some of the other ones, maybe 5th in a series that have been done over the decades. So I'm pleased in a small way to honor that report. So that was actually my first comment, that there's a long history of trying to figure out who we are and where we're headed. And I'm pleased that it's continuing. I mean, if you look at the field, I mean, the people here, the people there, and of course the people in the domain, it's tough sometimes to pull it together. Is it a discipline? Is it what we're focusing on? And I think the report did an excellent job trying to touch on those things, but it was also very practical and very focused on the future. So I personally, of course, was very pleased. I have not focused just on data and informatics in my career. In fact, they were just a tool for something else, primary care or integrated care. But now, all the things that we've been talking about, and the Institute of Medicine, which has been actually very central in promoting digital data, we're now there. And so I was very pleased to see a whole chapter in the report, and there are 2 or 3 points behind me. I estimate that 85% now of all interactions in healthcare are electronic, digitalized, but I also estimate that only 5% of such data are accessible to health services researchers, not including the Johns Hopkins data yet. We're working on it. So we have a long way to go, and so I would like to underscore that. And I think that not just for, as many of you have heard, I'm not particularly focused just on the data, it's what the data can do. And I think that all through the career of and the field of health services research, we have spent a lot of time on figuring out our data sources. And I'm very pleased that, although just slightly negative, but that's the way the life is, your funders were very heavily institutional. And of course, that's where the money is, the medical schools and the hospitals, et cetera. And I would like to have seen a broader representation of the funders. But to their credit, I was prepared to not see enough public health or population health in the report, but that didn't happen. It was in there. So that's really the only concern, is that we can't forget, even though the first health services research department in our school was called, did you know, it was called Department of Hospitals and Medical Care. And correct? I think that was its name. So I'm very pleased, and that again has been sort of potentially a weakness of academy health and health services research, that we tend to be medicalized. But I was very pleased that the report acknowledged that. So I could keep on going, but I'll stop. So those are just some of, to contribute to the history, as well as, I guess my main point is I hope that we could talk more in the time we have on the data.
Okay, well, I can jump in here. So I think we're at a place of tremendous opportunity, because the landscape around us is really changing, and the environment is changing. I mean, as long as we're sitting at 18% GDP and growing, and life expectancy relative to other industrialized countries lagging behind, there's going to be a tremendous pressure to try to figure out how we in our society can do better. And all of the actors, both on the public side and on the private side, are scrambling, trying to figure out how it is that we can get a better handle on quality and cost, and how we can improve health. And so even as we think about how we have been able to make advances in terms of just healthcare in the healthcare setting, the payers, the community are asking us to think more broadly and think outside of the physician-patient dyad, and think about those social determinants of health. And I think that gives us tremendous opportunity here. The other thing that creates tremendous opportunity is that our ability to collect data is just has leaped light years since I started in this field. We've gone from big tapes on reels to now data being uploaded from people's arms into a cloud. And so what that means is that for those of us who are in the field and studying, what we're going to have to do in the next 10 to 20 years is develop new techniques, be able to develop research projects that have validity, that can answer questions quickly because of the need of the persons who want this research and want to use this research, the way to use big data. One of the things in which we've noticed at Academy Health is when we do our annual meeting, we ask people in the room, those of you who don't work in academic settings, to raise your hands. And that group of people gets larger and larger each year. And one of the things in which we're sort of grappling with is how do we make the careers of those individuals who are working in those institutions meaningful? What does it mean to have a meaningful career in a non-academic situation? And what do we, as the persons who train these persons, what responsibilities do we bear to try to help their organizations figure out what a meaningful career is and how they can meaningfully contribute to the field? So yes, the environment's changing around us. Yes, the funding sources are challenged. But for us, this is we're scientists, right? We're academic. We like answering the difficult questions. Otherwise, we'd go home and figure out something else to do. But the in terms of what it is that we need to really begin to think about is really put our hats, our thinking caps on, and think about how we can get outside of this physician-patient diet and really incorporate new techniques and what new techniques need to be developed, and then how we can make access to all of this wonderful data that's being generated about individuals, how it can help people make better healthcare decisions, better health decisions, better wellness decisions, and also, because we're at 18%, how can we lower the cost of care to our society?
So I think I've been preceded by terrific preambles of the setting and the current environment. I also had something along the lines of saying that, what we're studying in health services research, it's a moving target. And it's a moving target that then defines health services research, and it gets increasingly cross specialties. But I wanted to sort of dive into one of the questions that Danielle has put up and address that, which is one that's very near and dear to my heart, given my recent transition from an academic setting into a non-academic setting. And I have to tell you that that's a struggle, and I think that's no surprise to anybody here. I can't tell you. So I defended maybe 3.5 years ago, and the number of hours that I spent with my cohort, we all sort of defended at different times, but we all have kept in touch. The amount of time we have spent discussing and fearing leaving academia is substantial. It keeps us up at night and makes these decisions incredibly difficult. I think I spoke with maybe half the room here about my decision to leave academia.
At length.
I definitely had a very long conversation with you about it. I recall that after the fact. So, and so I want to address that because I think that lays at the crux of then the gap that we find between what health services research ends up informing and the need that we have to inform policy a little bit more. Right now, and I think it has been highlighted in the NAM study, there are gap areas where we just need more information to inform policy. So policy is not largely evidence-based driven. I would argue that personal narratives and anecdotes that are at the heart of lawmakers and the news cycle has more influence in policy than a lot of the research that we devote lifetimes and so much love and so much thought about. And so how do we bring those two closer together? So I think that, yes, we're scientists, and as such, we sort of have this very long view, and that's very important. But that doesn't take away from the fact that we need also methods that are maybe not as, solid, or in our perspective, maybe not get so much stuck on the p-values and where to draw that line, but things that will help this rapid cycle, and to create a mindset that we need both, right? And that not everybody should do both or needs to do both. The way I see it is that there's two currents. There's a very long, drawn-out current that shapes pebbles, And that's the kind of policy that you see it getting built in. That's the kind of information that gets into policy over the course of 50 years. So Medicare, right? It took 50 years between understanding that there was an issue with our seniors going bankrupt over healthcare fees and having Medicare implemented. And granted, there's a whole political side of that is kind of it comes as it comes, that we can't influence, but everything else we can influence under that. Same thing with patient-centered medical homes. From its first appearance in journals related to pediatric care to the first pilot implementation, it was a 40-year timeline. And we need those. But we also need things that can inform towards items such as, is value-based purchasing working? What are the metrics to determine if the program is working? So the program itself measures whether hospitals are doing certain things, but there's nothing to determine at what point do we decide this is a good program or it's not a good program, right? At which point do we decide this is the right combination of metrics or it's not the right combination of metrics? So that's the kind of policy gap that we have. And so in terms of incentives, for academics, I think that right now the incentive, the track as it exists, which is that you come in, you have a certain amount of time to get your funding for your own research space, and then you get that funding, and now you have this fiduciary responsibility to undertake those projects, and that's your trajectory, right? And you have to publish, and you're tied to the timeline of applying for grants and submitting your papers for peer reviewed. And that timeline does not align with the policy timeline. The policy timeline is its own current. It's defined by 2-year appointments because the people who move the bills have 2-year appointments, and they have to get stuff done in 2 years, and they have to commit to decisions and positions in 2 years. And the people who write their legislative specs, the Hill staffers, they don't even have access to PubMed. So I think right there that highlights how there's these two sort of disparate currents that we have an opportunity to bring closer together. And so somehow shifting or allowing for a second track of incentives where we develop measurements along the lines of impact in policy or alignment with current policy needs would be a way to think about that. So coming up with these secondary paths that we'd have to construct them, but we'd have to shift what the incentives are and what the metrics of success are. So I think I'll stop there because I've gone on and on.
Great comments. Thank you.
Okay, I'm going to go back in time, like Jonathan, a bit, and then bring us forward in time and build on some of the comments. First of all, Danielle, also I want to thank you just for excellent report. And I think it's going to be extremely useful to the field. And I know there's a lot of follow-up on it as well. So going back in time, not too far from here, in a hotel room in Washington, D.C., around 1967, I think it was, I may be off a little bit, in the basement of this hotel room. Jonathan may recall this. He wasn't there, but he's probably heard this story. There were 4 of us who met, Stu Altman, Cliff Gauss, I think Cliff may have been at Hopkins at the time or before or after, myself, and Gordon DeFries. And we actually hatched the idea of the Association for Health Services Research, now Academy Health. And Stuart knew this young woman, Alice Hirsch, who became the first director and really did a lot of the work and got it off the ground. And very quickly involved a lot of others. Don Steinwachs was involved early on, and perhaps Jonathan was then too, and at the various universities we were at. And I remember I was kind of the very junior person there. I was a young assistant professor, and they asked me to chair or be the program person for the first meeting that was going to be in Chicago 2 or 3 years hence. And I said, okay. And I remember, I think our featured speaker at that first meeting was Karen Davis. Got Karen. Bob Blendon was another one I remember. And we thought we would be doing great if about 150 people would show up. We were really aiming for that because this was like created out of nothing. You know, health services research, you're going to have an association, you're going to hold a meeting. To our surprise, we got 375. Now that pales, of course, to the nearly 2,500 or 3,000 today, but it built up 4,000, Darrell tells me, today, right? But it built up from there. Two or three things, and we were alluding to it a little bit earlier this morning with some of your doctoral students, that are just totally so different from back in the 60s and 70s when the field was started. Number one, we didn't have data. We didn't have much data at all. It was in 67, 68, I think, or maybe 70, 71, that the legislation came about to create the then National Center for Health Services Research and Development, what is now called ARC, right? And that began slowly to build up some of the data sets. So to do research in those days was primarily you had to collect primary data. You had to go out and collect the data yourself. A few exceptions to that was some of the early health insurance plan of Greater New York and a few other places that had, some existing data that the economists in particular could draw on. But by and large, it was very sparse. And witness that today where we're just swamped with data, but maybe not so much information. And part of the job of the health services research community is to make information out of all these data. And if we could go back beyond that to knowledge, we'll stop short of wisdom, okay? But we go from data to information to knowledge, that would be great. And indeed, I think the report identifies some of the challenges in that regard. Speaking personally, we had a recent grant from Commonwealth, required linking to Medicare claims data, required to work with CMS, took us 9 months after the award to get the clearance from CMS to go into the ResDAC, and all this kind of stuff. And it's just ridiculous. We've got to get the research community and the foundations, along with the federal government, to come together and say, here's the end goal, here's what success can look like. Now let's deal with some of these barriers. Absolutely protect privacy, et cetera, but we need to speed up. We need a rapid cycle of being able to link these kinds of data. And so I'm hopeful that that will begin to occur. So we're just, the growth of data is a marvelous, as Darrell has said, and others, opportunity for us. Secondly, the research enterprise now, by necessity, requires team-based research. And so it's making this transition from, as doctoral students, it has to be your own original work, et cetera. And you have to have a first authored publication, maybe a sole authored even publication, to recognizing that to deal with the problems and the challenges and the opportunities we have today to move the country forward are not within the silos of an individual discipline, economics, political science, epidemiology, clinical medicine, whatever it might be, sociology. It's interdisciplinary. And you may be trained in a certain field, and that's good, but you have to learn and understand the language of your colleagues and work together as a team to address some of the issues. And this is much different from 40 years ago or so as well. So I think those are 2 or 3 big things. In terms of real-time research, and I think Claudia said it well, there's a lot of issues that take time to develop. And also remember that some of the research that gets funded that doesn't address in real time the Congress's need or the senators' need or whatever is still very valuable work because it lays an information and maybe knowledge base that can be drawn on 5, 10, 15 years from now. Things circle back. If you think about the Affordable Care Act, for example, 2010 now, right? A lot of that still drew on the RAND National Health Experiment back in 1968 on the impact of coinsurance deductibles with group health co-op, the work that Joe Newhouse and his colleagues did at RAND, okay? That was 40, 50 years ago. And I think that's still going to be true today. But on the other hand, absolutely, we need to find ways very creatively of taking advantage of the data available, the real-time data, to address immediate issues that face the leaders of our health systems, insurance companies, in Congress, and so on. So I'll give one example of where this could occur. I don't know how practical this is, but some of you, some of us, we're very interested in quality improvement kinds of research. A lot of research has been done on that. We're all familiar with PDSA cycles, rapid cycle, that a lot of organizations are doing every day. Johns Hopkins Hospital, Sibley, a lot of organizations doing these PDSA cycles, et cetera. Maybe they do lean management, maybe they have some other philosophy. They're capturing that data to make changes in real time to improve patient care. Is anyone capturing that information that they do within that hospital setting, logging it in or keeping track of it, putting it into some kind of database, that over a period of months or a year, you'd have maybe 100 or so projects done at Johns Hopkins? And what if that was done around certain other hospitals and health systems around the country that could then be accessible to researchers to bring some of that stuff to scale? You'd have the context measures from the organization that generated it, right? But you could begin to do some analysis of that. Maybe it'd just take you a couple weeks, with the computers we have today and so forth, turn that around and say, well, here's what it looks like. It wasn't just at Hopkins, but I've got a data here of 2,000 PDSA cycles across 25 hospitals, and here's what I'm finding, and feed that then in to various quality improvement initiatives that are going on. So that's just an example, I think, of what we can do. The other thing I will say in terms of the question about our trainees and our doctoral students and postdocs is I think we're beginning to get better at arrangements with delivery settings in terms of postdoc opportunities, right? So Geisinger has them, Mayo Clinic has them, all kinds of delivery settings now have them, Kaiser, et cetera, et cetera. And we're putting our students and postdoc opportunities into them. Out in the West Coast, we just got, this is really small change, I apologize in advance because I know I'm at Bloomberg, okay. But we got a $600,000 award from the Sutter Health System to create two $300,000 postdoc opportunities with the Sutter data, right? So like I say, that's chump change here, but it's a big deal for us. We've been working with Sutter for years to get them, more involved. So this is great. So we have two postdoc opportunities. Any of you want to come? Northern California, it's sunny today. It's sunny here too. Okay, so Al said I could recruit, I guess. But no, okay, but I think that is one thing that's developing we can take more advantage of. So I'll stop there and we'll see what additional questions we want to address.
So great comments and some challenges. I sort of like this little interplay between the question, we're scientists, right? And this sort of gets to the sort of what's the role of academia. Danielle was telling us that the incentives in academia aren't aligned necessarily to get things into policy. And we are teaching some of the right things, but we're not teaching some of the other right things, like how to persuade people who actually make policy that they ought to do what our data and our evidence tells us. Maybe the first step is to generate what the right answer is, but then maybe we should be having courses. We should have courses on writing op-eds and writing infographics and creating cartoons and videos and doing a lot of disseminating, not even implementing, but disseminating. But so what is the role of, are we scientists here? Or are we, in our daily work, we certainly are not training people perhaps as broadly as we should, but what about, what should we be doing as academics, or should we be joining the fray and becoming less academic?
I think, first of all, our program, one of its strengths, and I've seen some criticize it, is that it is very applied. It's at a public health school. We're training cross-disciplinary individuals who, you asked the question, can the disciplines get together? Well, most of our students are the multiple disciplines. In fact, they're sometimes criticized for that. I think wave the flag, that's a strength. I think that we can do better. I think incentives is behind me, right, Danielle? I think the incentives. I remember when I was an assistant professor, there was Karen Davis, when she was the chair, she said, Jonathan, if you want to get promoted, you have to publish in these journals. And the list didn't have health affairs in it then. Health affairs was a relatively new journal. And she said, well, we need to add health affairs, and we need to add 2 or 3 other policy journals. So I think the incentives, not just publication, but also having an impact, testifying. And for the students, I think it is a challenge. We tend to imprint most of a peer-reviewed article in a major medical style journal, and we need to do a better job of showing the range, and lest that we forget about the DRPH students. So we do have Doctor of Public Health students who now far outnumber the PhD students, and when you analyze it in terms, some of them clearly are going more into hands-on management, but most that's not the case. They're the implementers of with scientific principle of so much. So I would encourage us to think more. I'm sitting here looking at Colleen. I shouldn't. I should look at all of you. But I think as we lay out, and frankly, we have always been. That's our strength. But I keep saying some of the criticism. I believe I've worked with dozens, probably hundreds of doctoral students as they try to get jobs. That the applied organizations say, wow, they really can do something, but the academic organizations say, well, but our health economists or our biostatisticians or our sociologists can do that. Your students can only do that. Yeah, we can only do that, but in 10 different areas. Mm-hmm. So it's a delicate balance. I don't have the answers, but I'm just sort of laying out some of the applied issues.
Yeah, just to build on that quickly, Albert, the question going back also in terms of the research we do. But by the way, isn't it great to be a researcher, health services? It's better than being a detective, because when you think about it, detectives solve crimes other commit. We get to commit our own crimes and then solve them. By the nature of the problems we choose. I mean, the problems are out there for sure, but we choose. We want to do this, et cetera, and then we get to solve it, right? But I think part of it is there's no single answer, as we look at it. So it's how we talk about our finding in ways that those who have to make decisions feel more comfortable with than you found the answer. In other words, what's the portfolio of options available from our research? Maybe that hypothesis or that question or that idea didn't pan out. Do we have some other things, some reasons why that might be the case? And how do we communicate that? And then also, how do we communicate context? So I remember a conversation I had a couple of weeks ago, a person in California, access to the governor's office, talking about what's going on in Massachusetts and some other states. And then we got into this discussion, why that wouldn't work in California, context, what's different, et cetera. Yes, patient-centered medical home research, you got to look at the settings, the context, why you got a set of findings that look like X and then another set that look like Y somewhere else. So one of our challenges in health services research is the relative lack of replication, the relative lack of being able to study an issue longitudinally over time. That's becoming more possible now with the data sets we have. The ability to stay with an issue over time. So we, usually the grant runs out, we've got 1 year of post data, or maybe 2 years, and not the ability to follow that innovation for 3, 4, 5 years in terms of sustainability. Why wasn't it sustained when the grant support ran out, for example? Well, they didn't have the money. Well, why didn't they in the meantime, et cetera, et cetera? Well, reimbursement, okay, fine. So what do we know about that? So I think context is important. And then more directly is, yes, I think we do need to expose our students more to different ways of communicating our findings, whether that be op-ed. We brought in a writer, I apologize, it was from the Chronicle, which is our local rag, a newspaper in San Francisco, but we did bring in their healthcare op-ed writer a year or so ago to meet with us on how to write a good op-ed, and that was for the faculty as much as our doctoral students. So you can do things like that, but also to keep in mind that not everyone is good at those things or needs to be good, and there's trade-offs in the curriculum, but to know who to go to, who does do those things, and connect with them. So maybe you're not the person, you don't have time or whatever to write the op-ed or whatever it might be, or do the secondary dissemination, but there are others who is their job to do that, and you need to connect with them, and they can really educate you on how to do that in ways that doesn't take a lot of your time.
I'd love to build on that if I could. Yeah. I thought those were terrific points. And I also wanted to recognize that there are finite resources. And as you said, there are trade-offs. And we can't be all things to all people. But we can think in terms of what is it we're out to do, right? So are we out to just like write a paper and hope it helps someone at some point? Or are we out to actually influence change and get ourselves written into policy and see how these natural experiments, run their course? So I wanted to talk to a few of the different points, which is the longitudinal point, I think is very important. And I think there's, this is another reason why I feel health services research needs to be more impactful in policy. So a lot of the quality metrics, for instance, just to take an example, they change over time. They have to change over time because they get topped out, or because we, uncover that there's a measurement area that we weren't measuring before, and we can't be measuring so many things because then the healthcare organizations are completely burdened by collecting this data and sending it to CMS. But at the same time, we need to make sure that a lot of these measures stay over enough period of time that we can take advantage of these natural experiments in order to measure them. And so the voice of the health services researcher, the influence of the health services researcher is very important to enable the study of these things. Then we talked about teams. So absolutely, I couldn't think of the word cross-discipline either. Health services research is a cross-discipline discipline. But there's also value in single individuals knowing other contexts better. And so to the point that was made earlier, of having these postdocs in these healthcare delivery systems, that's really important. I think in the same way, we need postdocs or academics to spend some time in the government organizations so that we have people who understand the legislation and when rules are dropping and what rules influence what, right? So that we can at least understand where we need to engage. And then the final point we're scientists, are we something else? Again, talks to the point of what is it we want to do with this, right? So at some point in careers, people become influencers. And they become influencers because they've slowly been accumulating this wealth of knowledge in these publications. And at some point they're heard, right? Like they start getting calls from, to testify and all these things. But that is something that, there is also value in what more junior faculty are doing, and, leveraging the echo chamber and the social media and all these new venues that we have in order to speed up the influence might not be a bad thing.
So I just wanted to comment really quickly from the perspective of a previous student in building on what Jonathan was saying. I think one of the most influential moments that I had while I was a student at Johns Hopkins was I was taking a course on writing for policymakers, and we had a guest lecturer, and she came in and she said, all right, so a news camera comes up to you, they stick a microphone in your face, and you need to comment, a family has just had their son shot and killed. You need to talk about gun violence in the United States and the evidence that exists. What do you say? And she went around to, I think, 15 different students, and everyone started going right in with statistics from previous studies that had been published. And she kept moving on. She kept saying, no, we're moving on. What she wanted to hear was somebody say, I'm so sorry, that this has happened to your son. Mm-hmm. And here's the things that policymakers could do to make it better. And then here's the evidence to back that up. And I think that was really telling for me, because I really hadn't thought, I had been taking all these courses on research, as I really hadn't thought about how do I communicate this information to policymakers who are faced with constituents who have had these terrible things happen to families that they represent. So I thought that was just one of the most valuable experiences I had at Johns Hopkins, and I think it would be great to have more opportunities like that for students.
One of the things I learned, I guess it probably was at the Academy's Health National Policy Health Conference, that a good health services researcher not only helps policymakers figure out what they should do, they also oftentimes stop bad ideas from happening and becoming policy, and they do more sort of harm reduction than they do in terms of hey, I got a new bright idea, because they're in the room when the idea is proposed, and that because of their training and what they know about the healthcare system, healthcare delivery system, public health, they're able to say, no, I think that's a bad idea, and here's the reasons why. And so I would just say three things. One is that we do have a role in terms of training the people who ultimately end up being the users of our information. I mean, we have huge masters in public health and masters in so we train people who can use it. If we probably would help them understand patience, and the ability to to know what evidence is available. Yes, you have to make a decision now, but then this is an evolution. It's not, things aren't going to be etched in stone and stay there forever. This is what you need what we need to wait for in order to make a better decision tomorrow. And the other thing is that with regard to we are training people with DRPHs who are in these organizations and trying to give them the tools that they need in order to help their organizations make decisions, and then try to figure out ways in which we can help them share what they're learning with the broader field. I think we've in terms of the way in which academia has changed over the last 20 years, I think we were changing in the right ways, because we seem to value both teaching and practice more than I think probably a generation ago. We're trying to think about ways in which we can better measure practice. And that sort of gets into the area in which you, Claudia, were talking about, in terms of there's the things that we can write for our academic colleagues, but then there are other things that we need to share with the broader public in order that they can use our research. So I think we're headed in the right direction. It's just a matter of how quickly we can get there so that we can satisfy the demand.
Any comments from the audience? We've got lots of people who I know have a lot to say in their usual lives. Any thoughts on any of this? We've got a couple of mics.
Don't be shy. The first one is the toughest.
It's like popcorn. Kathy, what do you think about all of this?
I know he's going to call it. Well, okay, I do have maybe it's a comment and a question. What I was struck, I'm an organization theorist and was trained in business school. But I also have a health background. And in the first speaker's presentation, I was struck by the fact that when you put up the number of organizations that contributed to the report, there wasn't anything like the Academy of Management or any organization that does research on organizations. And I'd like to hear about that and any comments that people might have.
So I think that's a great comment. I mean, I think it's probably it doesn't reflect us thinking that that's not important. I think honestly it just wasn't on our radar screen, and it probably should have been.
Just a footnote to Kathy's comment. I think a few years back there was some kind of task force between the now National Academy of Medicine and the Academy of Management that tried to address that a little bit, how one could draw on the vast literature on organizations, some of it in healthcare, a lot of it not in healthcare, to inform, the agenda of the National Academy. And I think there may have been some kind of report out on that. I haven't seen it as such, but I think it's right to kind of underscore that linkage. Yeah.
And I mean, I guess if I can just say a follow-up comment, it would be that when we talk about health services research, that I think it's really important to think about the kinds of questions that you have up here are all questions that organizational researchers are dealing with. And it seems to me that facilitating collaborations among schools of public health and schools of business or management, I think would be really a salutary kind of thing to do, or to get people, especially doctoral students, involved. For example, one doctoral student, I has been working with several of my colleagues at the Carey Business School, and I think it's been very useful, right?
He got a job. He got a job anyway.
Yeah, okay, yes, say that now. We've learned a lot, and I mean, honestly, I think that if we think about the amount of money we're spending on research, we have to do this in order to solve these problems. And there's 50 years of research on the implementation of behavior change in organizations.
Yeah.
And we don't draw on that. We've created a whole new discipline of implementation. And I think it's really interesting, and I would love to know, I mean, we're thinking about doing some kind of symposium on implementation science and its relationship with organization theory and management, but anyway, I just want to put it out
So-
there. We have a lot to say.
Yeah.
A lot to say, and I think working together would be a cool thing.
Let me just pile on, Albert, a little bit. So there's a very active division of healthcare management within the Academy of Management. It's very active, and they increasingly involve students in that on podiums and so forth. So our doctoral program at Berkeley is similar to yours. We take in 4 or 5 a year, but increasingly the last 4 or 5 years, they are going as frequently to the Academy of Management meetings and presenting there as they do at Academy Health. For a lot of this reason, particularly the org management students, a little less so the economics track students. So I think absolutely that's the case. Yeah, and we need to do more of that. Yeah.
Colleen, are you bidding?
So this has been a tremendous panel. Thank you to Danielle and to all of you. I want to focus a little bit more on the communication question. So as a school, we're spending a lot of time thinking about how to communicate the value of public health and an institutional role as the #1 school of public health, yet again.
Today.
Good job. But I think that it's even trickier in some ways to communicate the value and the impact of health services research because, let's be frank, most of the population doesn't know what health services research means, and we are coming up against the press of medicine and the grateful patient. Right. And so to your point, Claudia, it's not just sort of anecdote, but sort of what are the stories of the impact of this work that we can tell, and I think encouraging a much more rigorous conversation as educators on how we train our students to tell those stories. And we began with some, but it seems like we're not doing nearly enough, and we as faculty haven't been trained or brought up to always be effective communicators. So can we talk a little bit, are there transformational things that we can do that go beyond a sort of little bit of communications here and there? And did it come up, I guess, in the work that your group did to produce the report?
So we didn't, during the meeting, we didn't get into how to train people to be better communicators, really. It was just more of a discussion around how as a field oftentimes, evidence is produced, you publish, and then that's you move on to the next project. And there's really not that second step of taking it and implementing it and translating it for lay audiences so that they can understand how the findings would be valuable to them. So I don't think that we got into the weeds in terms of how public health schools should be transitioning their education policies or practices, but I think it's I had that one experience, and I think it was really valuable to me, and I think more experiences like that would have been really great. But it, of course, is a balancing act, because also really great was learning how to do the research. And I think, if I had walked away from the school without knowing that, it would have not been a very useful experience for me.
So I want to start this comment by saying, I know we're being very focused on blind spots and sort of places to work, but I want to recognize that we're standing on the shoulders of giants, and we've come a long way. So I just wanted to put that out there, because I felt
Steve.
I hadn't said that yet. So I have a few ideas related to what you ask. Starting with the fact that I think the perspective needs to be that academia has a leg up on everybody else because you have the content. You have the professionals who know what the content is. Everybody else is scrambling to get that. And so then it does just become a matter of what are the mechanisms that we need to implement to then facilitate the storytelling or the more impactful ways of disseminating this information. And so one of the, I think, burdens of an academic is the fact that they have to be their own fundraiser, their own, they have to do their own publishing, they have to, get their students, and they have to, it's a lot of skills that one person has to contain. It's, every academic is a unicorn. It's really hard to find an individual who can do all these things for a sustained period of time. So I would say, don't put the onus on the academic to also have to be tweeting during the daytime. Make it like, I mean, some people are just more talented than others.
The National Academy of Medicine. The National Academy of Medicine has already retweeted Danielle's picture.
Yeah, I mean, I'm trying to build my own base, so if you guys want to follow me on Twitter, please. Salzberg, thank you. But, if as an institution you develop mechanics for deploying this, if you develop a focus into turning data and information into stories and that people can relate to and respond to, so the currency of social media, right? We need to take our language and turn it into the currency of social media. And then we need to target the people who would retweet and pick up on this and then turn it into, say, a legislative spec or, part of a program in a health system. And then just investing on developing narratives. I think that's going to become increasingly important, especially as we focus more and more in capturing the patient voice. And measuring the patient voice. So this is another area that really plays into developing narratives and being able to extract then data from stories. So going in the other direction, right? Yeah. I think we need that to move forward in any patient-centered metric that we're going to continue developing. So hope that helps.
I also think, Steve, your idea of placing students as a postdoc, not necessarily with another academic, but with an organization. Of course, we do a lot of that. I mean, most of our doctoral students are involved in our health system, and given that we're so close to Washington, D.C., I would say 70% of our students work with some organization. But we should spend more time on it and not view it as, oh, you mean you're just working with such and such an organization rather than working with Dr. So-and-so on his or her project. We should really value that and maybe even require that. And I think that that's key. Now, what organization? Is it a health system? Is it on the Hill? Is it one of the funders? By the way, don't you always look at the funder of an advertisement? In the New York Times, these make-believe organizations that are really pharma. So we need to be sensitive to, which is coming out a lot lately. And again, that was my criticism, but it's always been that way with Academy Health and with the Institute of Medicine. You have to find the support where you do. And let's not forget where the foundations got their money, Robert Wood Johnson Foundation. And, so it's tough. You don't have a lot. And I wish the Bill and Melinda Gates were focused more on domestic. So that is a challenge. Where do we get support for this stuff? We have to turn to the Association of Medical Colleges. Great people, but their issue 1, 2, and 3 is not our issue 1, 2, and 3. So we have to be open eyes on that.
Yeah. I would just add, Albert, maybe just a little story. Clint, I think it's a real challenge. It's difficult. And the same thing, what is public health, right? What's the elevator speech for public health as well? But a brief little anecdote, or true story about the difference between information and knowledge. Some of you maybe have heard this. You all know Peggy O'Kane, right? So this is a number of years ago.
Graduate.
You're great. That's what I mean. Yeah. Bloomberg Hopkins graduate, Peggy O'Kane. So she tells us a story about this some time ago, 15 years ago or so. She was giving a talk I was at, and she said, well, I was home cooking dinner with my husband, and our little girl, about 3 years old, was in the other room watching television, and she comes in the room, into the kitchen and said, Mommy, there's a baseball game on. So, oh, that's nice, honey. Yeah, okay, yeah. Little girl goes back out, looks at the game a little bit more, and comes back and says, Mommy, it's, it's really exciting game. And, okay, honey, find out, who's winning. So she goes back out again, looks at the TV, comes back in, and Peggy asks her, well, who's winning? Or, no, what's the score? 3-2. Who's winning? 3. Information, but a true story. She tells us a true story at the time. 3.
That's a really funny story. I was sort of toiling in my mind as you were telling this story, and I was thinking about, what is it that an 8th grader needs to know about health services research? What is it? And the reason I ask is because we're trying to develop all these tools so that consumers can make good healthcare decisions. So we typically think about the consumer once they become a patient. And then now we want to educate them on how to be a good healthcare consumer. But maybe we should think more, upstream. And think about what is it every high school student should know about health services research. What is it that when you go out and you're trying to decide, you get your first job and you have to decide what health plan to pick. What is it that you should know? What is it? What are the things when you go and see your doctor? Now that we want to have patient-centered medical homes, and the patient is the center, not the doctor. What is it that when you go and have that first wellness visit, what is it that you should be doing? And who's developing that knowledge essentially for those persons, since we think at right now, the way in which our society thinks is the way in which we're going to solve our quality and cost problem is we're going to make the patient a better patient, better able to navigate the system, better knowledgeable. And so we're creating all this knowledge, but we're not necessarily communicating it to the audience that needs to be able to use the knowledge. And I don't know the answers to those questions, but I'm thinking about, well, if I had an 8th grader, what would that 8th grader need to know if they're going to have in you have one.
That might be a great last word. It's a little bit of a. Incidentally, when you figure that out, my mother would also like to know what I do. And but maybe, and that's a joke, but maybe that we all probably repeat. At various times. But maybe it's a little bit sad that our mothers don't know what we do, and don't understand necessarily what the significance is. So in an article by Don Steinwachs in 1991, Health Services Research, Its Scope and Significance, the question he asked was, where does health services research fit into this picture? Can it guide efforts both to improve quality and simultaneously control costs? And he wrote, I believe the answer is an unqualified yes. Well, that seems a little bit optimistic, but this was a great panel, and I think I got a bunch of ideas, and I'm sure that others of you have too. And for that, we are very grateful to all of you for sharing your perspectives. You all really had something interesting to say, and thanks especially to Danielle for preparing the remarks. And thank you all for participating.